All right, good morning, everyone. Today is April 15th. I'm here today for our highlights episode with Jennifer Wagner. Has a PhD, she's a microbiologist, and she's certified in infection control by APIC and a managing partner of OnSite-LLC. So today she's going to be taking us through her work on airflow in new COVID-19 healthcare setups, and really with a focus on healthcare practitioners and their safety in these spaces. So Jennifer, take it away.
All right, thank you, Graham. Good morning, everyone. So briefly, at OnSite, we're a multidisciplinary team of scientists, medical professionals, and engineers, and we are dedicated to improving healthcare by applying research to the everyday profession. So in the wake of the SARS-CoV-2 pandemic, the role of the environment in protecting the healthcare worker from exposure to COVID-19 is crucial. Airborne infection isolation rooms have become a vital infrastructure, but there aren't enough of them. And so other spaces such as operating rooms, protective environments, and intensive care units are being converted into AII rooms, kind of on the fly. So the problem is that operating rooms and protective environments are positively pressurized. And ICUs, there's no requirement for pressure. So of course, when you're trying to prevent something like an airborne pathogen, such as a virus, what you want is a negatively pressurized room. Okay, next slide, please. So negative air machines are literally being rolled into some of these other environments that aren't negatively pressurized in order to try to get a protective environment. So the problem is that the airflow patterns that are created in these rooms can't be visualized or seen by the healthcare workers. And this can present a big problem in exposing the healthcare worker to the infectious agent if the airflow and the patterns are not properly designed. Next slide, please. So ASHRAE defines airborne isolation rooms and says they need to be negative, right? And so the reason for the negative pressure is so that you take the pathogen that's in the room and you prevent it from going out into other spaces where the pathogen shouldn't be, such as the corridor, additional patient rooms, things like that. So we want to get the negative pressure to take that pathogen out and away from unprotected people. ASHRAE also says that a negative AII room should have 12 air changes per hour with 2 from the outside and should be exhausted directly to the exterior and not recirculated. Unfortunately, when you're trying to convert other spaces into AII rooms, this may not be possible. So they've also given some other options for creating AII rooms out of patient rooms, protective environments, ICUs. So there are 4 other options for doing this, and we'll run through them briefly. There's another option, option number 6, which you see here, which is not ideal at all, because it's just putting a recirculating machine into the room. It doesn't create negative pressure, but if you can get it HEPA filtered, at least it gives you some filtration. Next slide, please. So the one thing that ASHRAE doesn't define and that we're trying to work through as we're making these rooms on the fly is where is your exhaust and where is your supply? And that's critical because as you can see with the little diagram at the bottom of the page here, if your supply and exhaust are not in the right place, you're going to be drawing that bioaerosol across the healthcare worker, potentially exposing them to the virus. So we want to try to make sure that we can start to visualize how our airflow patterns are running in these rooms so that we can prevent this unintentional exposure. Next slide, please. So the airflow patterns can't be visualized by the healthcare. And so our mission has always been at OnSite to try to make the invisible visible. And so sometimes that's difficult, and you can do that with bacteria, with viruses, with fungal spores, et cetera. And so we always try to bring research to allow us to find a tool to make those unseen things able to be seen so that we can draw them away and out of the room. So what we have done is developed over the last couple of years a way to what we call risk map. And usually this has been done in an operating room or an intensive care unit. And what it involves is being able to look at the environmental parameters in the room. So we're looking at humidity and temperature, air change rates, airflow, velocity, things like door openings, and all those things play a critical part in where the increased and decreased risk zones are. So specifically what we've done now is been able to take this information and this technology and apply it to these airborne isolation rooms. And really what the key is to make sure that you're taking that air from the unclean space, from the clean space over the unclean space and out the exhaust. Next, please. So in one of the ways that you can do this, you would take a HEPA filter or a fan, if you don't have a HEPA filter, and exhaust it to the outside, like through a window. So if you seal the actual exhaust in the room and you make a tight seal around the exhaust out the window, and you run this HEPA filter, you can bring the air from the clean space through the dirty space and out the exhaust. Now, of course, once again, making sure that your airflow patterns are going away from the healthcare worker and not across them. Next, please. So another way that you can do this is to take your HEPA filter and connect the duct to the exhaust in the room. And so now the objective is to take the air from the corridor and pull it into the room through the HEPA filter and out the exhaust. Of course, this can cause pressurization issues other places in the hospital, so you need to be aware of that too. But the bottom line here, again, is we need to make sure that the supply air and the exhaust are in the proper orientation so that you're not pulling that air across the healthcare worker as they're trying to treat the patient. Next, please. So another thing that you can do is exhaust the HEPA filter to the corridor. So again, probably not the ideal situation, but we do recognize, and ASHRAE recognizes, that in some of these rooms you don't have a window, and you might not want to exhaust out the exhaust due to what it could possibly do to the rest of the rooms in the hospital and other spaces. So in this case, you can exhaust to the corridor through a HEPA filter, which should help to protect the other spaces. So once again, same thing. You want to make sure that your supply air and your exhaust to the corridor are in a manner that you're not exposing your healthcare workers. Next, please. So in order to start to visualize these airflow patterns in the rooms and to be able to use this to protect the healthcare worker, there are a number of different ways that you can do it. So you can use smoke tubes, you can use tracer gas, and you can use velocity meters. And so, of course, smoke tubes release a glycol-like product that could cause residues to build up, but it can be used. Tracer gas, similar, different technologies that may require different things. And then, of course, there's an air velocity meter. And with an air velocity meter, you can look at the airflow in many different directions. So it can be horizontal, it can be vertical, it can be from top to bottom, it can be in a number of different planes across that field. And by doing this, you can start to look at the way that your airflow patterns are moving. And so if you look at the diagram, you can see that this allows you to, just as a smoke tube would do or as tracer gas would do, would allow you to visualize where your air supply is, where your exhaust is, and how those patterns are moving across the patient and across the healthcare worker. Next, please. So what we have done with a little bit of technology and some help from our partners at View Insight is we've taken this technology of air velocity and we've applied it to our algorithm that we've used in the past for operating rooms. And by doing this, we can predict where that risk of increased contamination would be within the room. And so on the right-hand side, what you see here is a dashboard. And on this dashboard, it shows you 5 different locations within the patient room around the bed. And then it shows you a couple different locations where you would want to collect those readings within the ante room and within the toilet room. And those are things we didn't necessarily talk about. ASHRAE doesn't necessarily address the ante room or the toilet room, but in some AII rooms, you do have these issues too. And you want to make sure that they are also properly pressurized and that the airflow is in the proper direction. And so going back to the main point of all of this is, however you manage to look at your airflows, however you manage to try to visualize this, just be careful that you are in fact making sure that that airflow goes from clean to dirty in a negatively pressurized space, so that you are sure to protect your healthcare worker from unintended exposures. So with that, I would just like to say thank you very much, and follow us on LinkedIn, check out our website, and feel free to ask questions.
All right, thanks for joining us today, Jennifer. Thanks everyone else for tuning in today. We'll be back on Friday at 10:30 with Dr. Stephanie Taylor. But Jennifer, thank you for coming and taking some time out of your busy schedule. All right, thanks everyone. Have a good day.